Welcome to the Bioptimizers Awesome Health Podcast. And now here's your host, Wade T. Lightheart.
What is Awesome Health? It's actually an acronym that stands for air, water, exercise, sunshine, optimizers, mental beliefs and attitudes, and education. These are the pillars of peak health, and my team and I have created a free 12-week course that you can use to transform. Each day, you'll get a written and video lesson delivered to your inbox. Everything is covered from the foundations of digestion to advanced alternative therapies few people know about. And again, it's 100% free. Just go to bioptimizers.com. That's bioptimizers.com.
Good morning, good afternoon, and good evening. It's Wade T. Lightheart from Bioptimizers with another edition of the Awesome Health Podcast. And boy, oh boy, am I excited today because we're going to talk about the transformational potential of regenerative medicine. And the idea here is to share with people some options that your GP may not provide for you if you are in a compromised state or you want to live longer and, of course, increase the quality of your life. And today's guest is Dr. Jeffrey Gross, who is a trained neurological surgeon who specializes in athletic injuries and spine procedures. He offers longevity and biohacking consultations. He's certified by the American Board of Neurological Surgery. He is a member of several prestigious surgical societies, and he also received Health Tap's 2022 Top Doctor Award as top neurological surgeon in the U.S. Dr. Gross founded Recellebrate, focusing on anti-aging and regenerative medicine. The mission for Recellebrate emphasizes offering modern biochemical treatments and considering surgery as a last resort. And that changes, that model is now evolving in a dramatic way. And who better to help us navigate that world than Dr. Jeff? So welcome to the podcast.
Thank you so much. It's my pleasure to be here. Appreciate it.
So, I've got a lot of friends who are surgeons. For some reason, there's this incredible explosion of surgeons who are using regenerative technology, first as an adjunct to healing, and now what you're suggesting is there may be some of these things that you could do to avoid, surgery and leave that as a last option, or to be able to, if that is what's required, to be able to use these to, accelerate healing and, regain mobility, which is a big factor in aging. We have muscle mass, then cardiovascular health, and then really it comes down to mobility. And the combination of those three is what we feel is living long and living strong. Before we start on that side, can you give a little bit of background? Because I think a lot of people really don't understand how difficult it is to become a surgeon. And what was it like? How did you get into that field? What drove you into that field? Because it's like a long, long time before you actually perform surgery. Can you kind of outline what that process is for our listeners, to what gives you a unique perspective on this? Because essentially surgery is doing one injury to mitigate some other injury, and then the body does its healing process after.
Right.
So what's your perspective on that whole thing, and what got you into this, life-saving space, essentially? Like, surgeons save lives and they increase the quality of life.
Yeah. Well, that's the underlying goal. And it's a funny thing, the way you asked this is, when I went through school and all this training and years, and I was 34 years of age when I started my first job outside of training.
How many years of schooling?
So I let's see, 4 years of med school after college, 7 years of residency, postgraduate training. So, if you go through high school and that's, 12th grade, then 4 years is 16 years plus 7, So I guess all in all, it's 23 years. Did I do the math right? So
Yep.
23 years after kindergarten.
Wow.
Yeah.
And now you talked about, your background's neurological surgery. How does that differ from, say, joint surgery, and then maybe what might be concordant if there's any elements?
Yeah, they're totally concordant because I'm a spine fellowship trained neurosurgeon, and about a lot of what neurosurgeons do besides taking care of the brain is take care of the spine. And I did most of my practice has been spine over the years. The spine is made up of joints. They're different kinds of joints than a knee or a knuckle, but they're joints. The disc is one of the joints. The facet joints in the back of the spine are some of the joints. So these are mobile segments. So we have a unique understanding of the spinal joints, and we can extrapolate some of that to other joints.
That's really pertinent for that. And what was your best part of being a surgeon, and what was the most challenging part? And then maybe the third piece I'm going to ask to that would be, what led you to focusing on the area you're in now? Because there's usually a composite of those two polarities.
Well, I think the best part is, most surgeons or people, the high achievers, want that high you get when you fix someone, when you remove someone's pain, when you save a life, all the things that are written about in the Hippocratic Oath, right, is to relieve suffering. And when someone comes in, walks in, like, hey, my leg pain's gone, doc. I mean, that's the best, right? That's the feel good. That's the reward. So I think that answers a lot of that. But I transitioned from a lot of traditional neurosurgery out of frustration in needing an updated tool. And having practiced spine surgery for over 25 years, there's a lot of surgery, and there are a lot of patients who are not ready for surgery, but they still have problems. And maybe they didn't fully find relief from therapies, injections, and things like that, but they're not ready for surgery. And frankly, surgery hasn't changed drastically in decades for the spine. So I listened to enough patients, helping to find a new tool to fill that gap short of surgery. So whether we delay or push out surgery or make it unnecessary, even better, we were seeking to find something additional to help the patient heal. So a lot of my patients stimulated me. They said, hey, doc, what about stem cells? And finally, I said, you're right. I'm going to go back and get retrained. That's of interest to me anyway. It was part of my undergraduate years and that part of science. And there was an academic reawakening, and a lot had been done in the 30 some years since I had my undergraduate degree. So it was time.
One of the unique components that I always find, fascinating for my friends who are surgeons, and one of my first friendships in the surgery field is Dr. Horst Filzer, who was part of the Harvard team that put the first stent in the body. And he shared with me similar things, is that he was always excited to have that ability to save lives. But what's very unique about surgery, say then from your general practitioner, is you really can't afford to be wrong. The consequences of making a mistake are so severe, especially when you're dealing with spine and brain. So the level of training, I think, and also confidence in what you're doing, both in the diagnosis and in the actual procedure itself. It's not like, hey, here's some pills, maybe they work, you come back, we try another round. Like surgery, especially in that area, is really, how did that kind of training confidence equation translate over when you started using, which we'll get into, like the use of stem cells in recovery or regenerative medicine, or is it preventative maintenance? Like what changed that thing? It's like, well, maybe we don't need surgery, we can do this first.
Right. No, that your last part was spot on. Surgery is very demanding. It can be very stressful. And one of the reasons that a neurosurgeon has 7 years of training, and And then, repetition upon repetition of doing these things over and over again is to help not screw it up. So, you want someone who has, a little bit of OCD and it just does everything perfect and is very demanding. So I love the technician piece of surgery. I love the concrete jumping in and fixing something, is very exciting. But it wasn't really advancing. I mean, if you look at what spine surgeons do, we do one of two things. We either make more room for the nerves, called decompression, or we fuse the spine. We lock mobile segments together, or some combination of decompression and fusion. Yes, there are new bells and whistles, new approaches to it, new screws and rods, but those are the two things we've done for many decades. And some of those things are very open and barbaric still. Mm-hmm. And there was a day and age, I mean, in the 1960s and maybe early 70s, if you had a bad bone-on-bone knee problem, you got a knee fusion. You didn't get a knee replacement. They didn't exist yet. So,
wow.
So the orthopedists made a jump, and and then now we have something in spine called the artificial disc, but we still decompress and stabilize with a mobile device. Mm-hmm. It's still a pretty big. You have to remove the engine head to get to the parts, right? You have to do, like you said, you have to kind of create an injury to get there, even though we have minimally invasive things. So that's one of the frustrating drivers, or the driving frustrations, if you will, that got me there, and let me add regenerative medicine as a tool. I haven't removed surgery from my practice. There's a role for surgery. I'm hoping to diminish that role for people I see.
What was it like as a professional to kind of branch out that, where you have, boards and regulatory bodies and, colleagues and all of those influence? Was that met with a lot of positivity, or was it met with, I don't know if you're going down that road? What is the general census in the surgical community?
I'm going to come at this from a few ways. First is, my duty is to my patients. So if I'm helping my patient and I give them one more option that someone else hasn't even mentioned to them, I feel that that's the enhanced informed consent and enhanced level of service. So I've been in practice long enough that it doesn't matter what the guy next door says, or some, stodgy group of, bow tie wearing pseudo academicians who call themselves the committee or whatever. It doesn't matter what they say. It doesn't matter what insurance will pay for or not. It's what's best for people, what's best for patients. So at the end of the day, I guess I've finally learned not to worry about what other people think so much, as long as my patient has full knowledge and is happy.
And one other item before we get into some of the stuff that you're doing that I think is really pertinent. How do you feel about, like, not only are you informing someone about an option, but how do you see what constitutes a good patient when they're going into a meeting with a doctor? Because oftentimes what I find is, people aren't trained in this area. They were out of school early or didn't complete, even 12 grades. And when all of these, weird words start coming out, and these, oftentimes life-threatening or certainly lifestyle-threatening conditions, and also they're in a certain amount of pain, obviously, or suffering. That's why they're at the office. What do you think is some pertinent advice that you would suggest for someone who is considering surgery, or how do they handle being a good patient when they don't understand things and are just like, oh, well, my doctor said so, and that's it?
Well, we could do a whole separate podcast on a tutorial on how to be a better patient, so your doctor can figure you out better. But I'll try to bullet point this briefly. First of all, if you're facing surgery, or that someone gave you the idea of surgery, get more opinions.
Right.
Get opinions.
Choose free opinions.
At least, I mean, get older opinions from older, experienced doctors. Get opinions from younger doctors fresh out of training who may be more familiar with the latest techniques, or have been willing, or have been trained on them, or have a different view. This is the first key. The second key is make sure that physician that is going to do surgery on you, if you're looking at surgery, has spent time with you and has examined you. I'm amazed. I do a lot of second opinions. I see people with botched surgeries or what have you. I do a lot of second opinions where people come to see me and I say, "Where's your pain?" And they say, "It's in my back." Okay, well, show me in your back. Your back is a large piece of real estate. It might be your spine, it might be something else. And I examine their back and they say, "Doc, you're the first person that's touched my back." I was like, "What do you mean? You had another doctor even do surgery on you and no one's touched your back." So make sure your doctor examines you. Make sure the doctor asks you lots of questions. Make sure you have had all your questions answered. And in this era of cookbook medicine, MRI-driven medicine, and 5-minute visit medicine, something's going to get missed.
Yeah, it's impossible to do an assessment on a restaurant menu in 5 minutes if you haven't been there before, let alone your spine.
Right.
Thank you for that tidbits, because I've always encouraged people to get multiple. I think a lot of people mistake of what that the doctor surgical or the doctor patient relationship is, especially when it comes to surgery, because surgery generally is a permanent change. It's really hard to come back from what's been done in order to do that. And hopefully that's for the positive.
Right.
But if it's, there's risk inherent within that. Doctors are only humans, and you're entrusting them with essentially the quality of your life and maybe your life in many cases. And so you want to be, thoroughly give yourself the best chance and be confident going into it. So thank you for that.
Sure.
So let's talk about some of the things that you're focusing on now, which is, regenerative technology. So what's the latest and greatest, and what's got you excited in this particular field?
Great. Well, I'm excited by results, right? So I went and about 5.5 years ago said, I'm going to stop going to these annual spine meetings where we talk about the same old stuff. I still go, but instead, I'm going to start going to some other courses and annual meetings. And I went to regenerative medicine meetings, and I started to piece together a la carte the best practices and the latest techniques and technologies to offer my patients. And that has blossomed more than I could have expected. And now, as a spine fellowship neurosurgeon, I'm treating spines, and I'm treating other joints, and I'm treating other kinds of issues that I never thought I would. But so what I've done is, at the time I was looking at regenerative medicine, you had really 3 levels of biologic healing, and that's involving assistance through PRP, as you know, as platelet-rich plasma, which is very low level, comes from your own blood. The next level up would be stem cells, which can come from yourself or from a donor. And we can maybe get into that if you like. Yep. And then the third level would be what are called nanoparticles or extracellular vesicles or exosomes derived from stem cells, which have some advantages over stem cells. So these have only been around probably and available for 8 years or so. So I came in at the right time. I'm very excited about the simplicity and the efficacy of the stem cell derived exosomes. Then I looked at how they're applied to the spine, because I was getting into this to offer to my spine patients. And some of the best work has over 15-year follow-up data from Europe. In Europe and Asia, literature is probably 10 to 20 years ahead of North America. There's no doubt.
Is that because of what happened with the administration during the Bush administration, when they kind of stopped a lot of that research and that was continued around the world?
Probably. I mean,
yeah.
So there was no federal funding for stem cell research during that time. And then clinically, it's less, it's harder to find here in North America. So now, in the Americas, you could still go to Central America, Mexico, and find stem cell clinics, and they're still there, and they're popular, and they can advertise. So you see a lot of them, but you don't have to leave the States, and I'm not certain about Canada, but you don't have to leave the States to find regenerative medicine clinics. They're everywhere. We just can't advertise. A lot of people, there's a myth that it's illegal to do regenerative medicine. It's not illegal. However, it's not yet approved to make claims that we're curing or treating anything. So we have to be very careful. We're always upfront about that. Doctors can't guarantee anything anyway, so it's sort of a silly thing. And just so we're clear, FDA hasn't approved those claims. They also haven't unapproved them. It's
Right.
an unadjudicated. People only hear the one side of that, you know. So if you want the government making your treatment decisions, this isn't for you.
Yeah, and in Canada, of course, it's state funded, and last year the life expectancy for Canadians has dropped, I think, 4 years within the last 8 under the current regime, and I think last year over 50,000 people died waiting for just all sorts of surgeries because the amount of doctors they have available to the amount of people that need help is disproportionate, and that's a whole other area. And then here in United States, of course, a lot of it's based on how good your insurance is and how much resources you have available is going to determine the options that you might have. Now, outside of the country is a whole other ball game. And so I guess basically what you were doing is saying, hey, I'm trained to understand literature. I'm trained to understand good studies, bad studies, longitudinal studies, these type of things. I've, examined the areas that weren't, limited by the amount of experimentation and research that gone into it. And I've come to these conclusions. And now I'm taking those conclusions, just because they happen in another country doesn't invalidate them. And that's probably why we're in this sort of gray area, because the regulatory bodies haven't been able to integrate this through the funding system and all that, how that institutional bureaucratic funding and all that stuff happens.
I might slightly disagree and say it's only gray because they say it's gray.
Right. Yeah. Okay. Beautifully said. And I deal with this in the nutritional supplement industry the same way. For example, Canada, I've been trying to get my magnesium product into Canada for 4 straight years, and it keeps getting disqualified by Health Canada. It's magnesium, for Pete's sakes. You know what I mean? And it's just, meanwhile, it's selling all around the world, and there's been no negative consequences that would be considered life-threatening or health-threatening on any level. I think a couple people got the runs because they took too much, but So what are you doing in your facility, and what are you offering, and what are you most excited about?
Right. So turning back to that. So at the time I said I'm going to start, offering this to people, you would think, okay, we see a lot of disc problems. I treat the spine, right? People have slip disc, degenerated discs. Some people use this crazy phrase, degenerative disc disease. There's no disease. It's age-related and accumulated trauma. There might be some genetic predisposition to certain things, but really, they gave it a disease so that they could prescribe more pain medicines. These are all the codifiers and the agencies that are government sponsored to do this. So again, if you want your government deciding what you have and what you need, then keep seeing your regular docs. But the best practices at the time were in head-to-head trial in the French. Dr. Philippe Hernegau, orthopedic doctor in France, took patients who had end-stage knee degeneration. We call that sometimes bone on bone. We call it osteoarthritis. These were people with painful, dysfunctional knees, and they had already been offered a knee replacement, because that's what's on the menu for bone on bone when you failed all the gel injections and that kind of thing. And they found that and they only had stem cells when they started this study. They did not have exosomes, but we'll come back to that. They injected stem cells in these patients who were offered knee replacement. They took some of them and they said, hey, join our study. Half of them got injected in the meniscus, in the joint, which is very similar to a disc in the spine of sorts. And half of them got injected in the bone, just above and just below the meniscus.
Oh, wow.
And what's in the bone? What's in the subchondral bone, we call it? That means just near the cartilage. Well, there are cells there. What cells are there? Cells that make the proteins of cartilage, that make the chondroglycans and the chondroglycans and others. And I'd have to go back to my biochemistry text to list them all,
I remember
proteoglycans.
the chondrocytes or something.
Yeah, so the chondrocytes.
Right?
So
Yeah.
also our bone marrow, our stem cells from the bone marrow are there. And as we age, they're not as functional, right? Just like all our cells. And think about it, at the edges of your bone are your growth plates. Now, the growth plates aren't as active when you're done growing, but there's a very important biology happening in that bone. And it turned out that at about the 5-year mark, a lot of those patients did great. The bone group did a little bit better. At the 10-year mark, they started to separate, where the bone group was still cooking along doing great, but the joint group started to lose some people back to having joint problems again. And at the 15-year mark, that was published in 2021, so yes, we're coming up on 20 years, I hope they publish, it was about the low 80% of the bone group were still having no problems. That means they escaped the need for a joint replacement.
Wow.
But the meniscus group was down into the low 20%, were still doing good. So there was a decay if you had the joint injected. There was a pretty good preservation in the group that had the bone injected. You might say, well, can those joint people then go have the bone injected? And the answer is probably yes, but that wasn't part of their study. So I extrapolated that to the spine and said, injecting the disc does not make sense. There aren't a lot of cells in the disc. The disc is biological rubber of sorts. Mm-hmm. There's not a lot of biology there. The disc gets its nutrients and its blood flow and its life from the bone above and below. So I started injecting the vertebral bones in the same way. So we do this, it's an injection. We do it at a surgery center under sedation, twilight sedation, because we are injecting the bone. And I'm injecting stem cell-derived exosomes right into the bone. And we target this based on a pre-treatment MRI with a very special sequence called inversion recovery, where we can study the bone marrow very good. And we see these dying edges of bone. And we target to reanimate that bone, reactivate someone's stem cells, calling upon the factory, the original factory that helped produce that portions of the disc in the first place to for some original factory parts, help us reinvigorate that disc, lay down some more cartilage. And I do this for knees, just like the French, and I do it in other joints. And we have some wonderful MRIs before and after with knees showing restoration of the height of the meniscus and the articular surface and restoration of the cartilage, matched with clinical improvement, of course, which is the most important thing.
Can you explain for our listeners the difference between stem cells and exosomes, or the classifications of stem cells, etc.?
Right. So remember, when we're a fetus, we're an embryo and a fetus inside of our mother's womb, we're developing into this human, this baby human, and we start out with, as the embryo, a ball of cells, and those cells are actively able to divide and become the next group of cells, and that group becomes the next group that maybe makes a heart or an organ or a limb or a brain. And those are stem cells, because other cells stem from those, right? It's the source of cells. It's the source of making a person. And when we're born, we still use those stem cells to grow and develop and heal. And when we're done growing, we reach sort of a steady state, but we still tap into those stem cells, which aren't as powerful, can't create a new human out of them unless you reverse them, which is called induced pluripotent. We retain what are called multipotent stem cells. They can divide into different tissues we need, liver cells, skin cells, and we make those all the time. So we're using our stem cells. And if we need to heal, like if you cut yourself and you need to heal, you're calling upon stem cells, for example. And as we age, our cells become less useful, and that also befits our stem cells. So that's why we need help. And what we're doing with regenerative medicine is tapping back into our own natural blueprint to just reinvigorate and activate a youthful, restorative, regenerative healing path. Oh, exosomes. All right, I was going to get to that. So now that you know about stem cells, it turns out that if I were to inject you, Wade, with some stem cells right now, I've got these great stem cells, just got them, I'm going to inject them in you, they'd be gone within 10 to 14 days. But their benefits would be lasting probably weeks and months and what have you, and whatever improvements they did would continue to give you benefits. So if the benefits last longer, but the cells are gone, what's going on there? Like, that's interesting. Well, it turns out that the stem cells are delivering cell-to-cell messaging to your cells and your stem cells. That messaging comes from small particles that one cell delivers and another cell intakes. And those are very small, meaning cells are small anyway, right? They're measured in microns or micrometers in diameter. Well, about 1/1000th that size is measured in nanometers across, and these are called nanoparticles. And they are a small bit of membrane with a little bit of growth factor in there and a little bit of microRNAs sending a message to a recipient cell. Hey, stop goofing around. Wake up. Activate your anti-inflammatory healing processes. Make what you need to make. It's like if you took an older decrepit person and you give him a bunch of testosterone and you optimize him and you give the right peptides, you give him a bunch of IV fluids and get him back in the gym. I mean, it's like that. You completely reawaken the sleepy cells. So the whole process of this exosome message from stem cells is, hey, all your cells can get a little boost of this love, and that can last longer. Exosomes are smaller, they penetrate tissue better, they last longer, they can cross the blood-brain barrier. Stem cells don't very well at all, they're too big. And we can get them at about half the price.
Excellent. And you mentioned one other item, I think, that's used in regenerative medicine right now, and that's peptides. Can you kind of classify what peptides are, and are there any specific peptides that you're using in your practice in conjunction with stem cells and exosomes?
Sure. And let's be clear for the audience that the king of peptides is asking me what a peptide is. So Wade, you're an expert in this area, but generally speaking, peptides are small protein fragments, right? And our cells exist to make all kinds of different proteins can be called enzymes or what have you. But some of the most basic proteins are cell-to-cell communicating proteins, growth factors, hormones in our body. And some of the smallest hormones are small enough to be called peptides. And even smaller ones can be called bioregulators, which are even smaller peptides. If you've ever heard the word endorphin, which is this small opioid molecule in our brain, that's a peptide. Melatonin is a peptide. Have you heard of semaglutide? It's a peptide. Okay, so peptides are small proteins, but some of them are very strategic fragments that can bind receptors and can influence what genes are active. And some of these can help organize the cell to do better things. For example, most of our cells, after being exposed to the world for so many years, are busy in this chronic inflammatory defense mode. And that's not best optimal mode of operating. We want to be in an anti-inflammatory regenerative mode. We want to go from degeneration to regeneration. And to do that, sometimes we can use peptides. So a lot of people that I treat have joint problems, spine problems. So we like some of the ones that are foster healing, like the BPC 157. We use some GHKCU. We use some thymosin, sometimes alpha and the beta particles. There are so many more these days, it's hard to keep up.
Yeah, it's fascinating. And when peptides first came out, I was very mindful. I'm very sensitive about what I'm going to allow to experiment from. But with PPC 147, TV 500, GKCU, I mean, those things are so well documented. And there's with all of these treatments, what I think what's really unique than, say, pharmacological agents is the side effects are minimal to non-existent. What are some potential problems? We always want to be transferred with any of that stuff. Have you seen at all?
Well, I mean, with semaglutide, you can see, people say, "Oh, my stomach's a little upset." So, yeah, that's one of the ways it works. You don't feel like eating.
Yeah.
But I haven't really seen any problems with peptides. I think that I've seen inefficacy in some of the oral peptides. And this kind of makes sense to me. Very few peptides are oral. One of them is actually BPC 157, can be taken orally, but it just doesn't make sense to me because we have enzymes in our stomach that degrade, that are meant to degrade and break down proteins like meat and into their amino acids so we can reuse them the way we want. So because peptides are made of amino acids, it's just hard for me to see how those work orally. But I guess BPC 157 somehow is protected in the mucosal lining of the stomach or something.
Right. And then it's kind of this weird regulatory pressure right now on the use of peptides and their accessibility for people in the United States, despite all that. Why is that, do you think? Are they being misused, or they're not guided, or what is your perspective?
None of that at all.
And now for a Bioptimizers fixed digestion tip. Supercharge your protein shake. Everyone knows protein shakes are a great way to sneak in extra protein, build more muscle, even replace meals and burn more fat. The problem is the highest quality protein typically absorbs at around 40%. One way to fix this and dramatically increase how quickly and effective your protein shake digests is to add 2 to 3 capsules of masszymes into your shake. One research study showed that pre-digested protein during a meal increased muscle growth significantly. To take advantage of this, just blend the open capsules into your shake, and within 15 minutes or less, the enzymes will have begun to break down the protein into amino acids. This can make your shakes at least 2 to 3 times more potent. Some people do this and sip on their shake while lifting to provide their muscles with a steady stream of amino acids during their workout. To save 10% on masszymes, use the code SHAKE10, that's SHAKE10, at masszymes.com. That's SHAKE10 at masszymes.com.
There are people who make a lot of money selling chemicals for diseases called Big Pharma that are at risk of losing money if we start helping everybody with more naturally or bioidentical peptide products.
So I've had a number of friends, both recreational athletes and professional athletes, that really had certainly career-ending or career-altering injuries, knees, hips, shoulders. I even had a significant shoulder injury a couple years ago, which was impeding my ability to compete at the Mr. Olympia. And then I used some of the things that you're recommending here with a surgeon here at Los Angeles, which was really cool. And, I was in a state of literal excruciating pain and immobility and, probably 90% weakness at its peak. And had gone through this for a long time and tried all these other methods, and they said, went down that route, use a combination of stem cells, exosomes, and peptides, along with some shockwave therapy and some microcurrent being a current that can open up the cellular chambers, especially in a damaged area, get out the toxins, and then let the nutrients get in. We found that was even better if I combined all of those things. Unfortunately, have access to people in those fields. And it was remarkable, the transformation that happened in my shoulder, so much that I quickly regained full mobility to the point I would say I've run 95 to 98%. There is just a tiny little bit of residual damage left over, but it doesn't impair me in any way. If I sleep on it the wrong way, I got to do some extra stretches and stuff, mostly from spasming of the muscle tissue. And prior to that, my coach had said, listen, Wade, this is not going to get better. And he was a coach of hundreds and hundreds of professional athletes at every single level. And he said, this is part of getting older, and you're just going to have to adjust to the realities of this in your career. And I refused to have that as an thing, as much as I respect him, and I'm not trying to throw shade at him, but I felt that he was impaired by not looking at these examples. Yeah. And he had also suffered he had to get spinal fusion in his life because he had done crushed some vertebrae and stuff like that, and had a poor reaction to painkillers and a whole history of things. But now there's these new options and you talk about this, is that oftentimes younger doctors or people who are more cutting edge or who are a little bit more open will look outside of maybe what's, coming down from the American Medical Association, are now using these with, extraordinary success. Where are you using them in your clinic? And let's say someone comes in with a knee injury, or someone, like kind of the standard injuries that you see. What are the standard injuries? And then what is your standard kind of way of looking at them, I guess? And I know we're just saying generalizations, every person.
No, of course, of course. No, I mean, it depends on the patient's appetite. My menu's longer than it traditionally was before, because you talk about the kind of the old school doc. In a way, I was that guy, until I said, yeah, okay, a lot's happened. My training ended in 1999. It's time to, teach the old dog some new tricks. So I take patients like that, and we first of all make sure they are optimized in epigenetics, lifestyle. Okay, you want to heal from this? Are you doing the right rehab? Are you doing the right exercise? Are you not doing too much? Are you not hurting it? Are you strategic about it? What's your diet like? Is it inflammatory? Are you working towards a clean and natural and green, heavy diet? Are you getting enough protein? Is it good protein? So how's your sleep? How's your cellular restoration period during the dark phase, during the circadian rhythm of night? Which parenthetically is one of the reasons I think I was open-minded to a lot of this stuff. Is when I started my career, I was told that the average life expectancy for a surgeon was 68.
Right.
And after a few years of taking, call and being up all night, and even on the nights I wasn't on call, I was not sleeping deeply because I was waiting for my pager to go off, if you remember what a pager is.
I do.
So at some point I said, I'm not going to do this my whole career. And once I started sleeping and dreaming again and sleeping deeper, I think sleep is an important contributor to longevity. And if you talk to people who do longevity full time, Brian Johnson, who spends a lot of time and money on that.
Yeah, boy, does he ever.
But he'll tell you, I've heard him on podcasts, and he'll say, hey, listen, I do a lot of testing, I do a lot of this, I do a lot of that. But if I could just, give you the basics, it's diet, it's supplementation, it's sleep, and it's exercise. So if you can get those in there, for starters. So I start everyone with that, because even if we're going to talk about adding regenerative medicine, adding stem cell derived exosomes or something, even IV for healing or peptides, we got to put it into the best and receptive and optimized environment. Otherwise, you're not going to get your money's worth. So we start there. And then we add what other elements someone might have an aptitude for, an appetite for, and that could be peptides. It could be IV regenerative medicine. It could be, the type of regenerative medicine I do more of, which is right in the bone adjacent to a joint or wherever the injury is. And we do shoulders and we do ankles, and we've done osteoarthritic fingers and things like that. So we do a lot.
That's great. So what is the most common injuries that you see people coming in for? And then if they are, say, open to a variety of things, how do you maybe steer them or suggest, hey, maybe you should consider doing this before you do surgery because we might not need it, versus, you know what, there's nothing you can really fix at this point. We've got to do surgery, but here's what's after. So what's your thoughts on that kind of decision tree?
Well, I'd say that, and not everything is necessarily injuries per se, because we see people with sort of chronic progressive accumulated low back pain, for example, which could be measured as a lot of little injuries that added up.
Right.
But we see plenty of low back and neck pain. And there are some problems, for example, with the discs that I don't have a regenerative medicine solution for. For example, a couple hours ago, I was on Zoom with a client of mine who has a degenerated disc at one level and a significantly herniated disc at the next level, compressing a nerve, causing him a weakness in the foot. And I said, look, all the regenerative medicine in the world, I just don't know how I'm going to help that herniated disc that's pressing your nerve. There's still a role for surgery. And I think you need a microdiscectomy to clean up that piece and take the pressure off the nerve. Then we could talk about regenerative medicine to, help that area, maybe slow down its degeneration, having had a herniation and having had a small surgery, or the other degenerated disc. I said, I don't know if that's causing you back pain or not, because I don't know which disc is causing you back pain, but I know that foot is weak because of the herniated disc. So we could do something regenerative for those degenerating discs, but we're really treating both problems, slightly differently, but we could do it at the same time.
Yeah, that's really cool. And so is it back stuff that you get mostly, or what about knee stuff, hip stuff, shoulder stuff, or neck stuff?
I am getting an increasing number of knee problems. And I think I see the way my practice is trending. I'm going to be the one spine fellowship trained neurosurgeon treating more knees in his practice than spine soon.
So let's talk about knees particular, because I know there's two surgeries. So if I extrapolate myself out to the general public, my aunts, my uncles, cousins, stuff like that, there's an extended family who are not in my space at all. The most common elements that they get is knee surgery and hip replacement surgery. Those are the two ones. You get to a certain age, you're like, oh yeah, I got my knees done, or I got my hip done. And certainly the relief from suffering is, for most cases, is pretty good. But are you suggesting that if preemptively, diagnosed and corrected, that you can maybe avoid that altogether? And what would your,
yes,
other than what you've talked about lifestyle, like how do you determine whether you're one of those candidates or not?
Well, anyone trying to avoid surgery could be a candidate. The people who are not candidates would maybe be on a blood thinner, and we can't do an injection for some reason, but those same patients can't have surgery either. So
Right.
you temporarily go off the blood thinner. We don't have enough data to know whether the exosomes can or can't affect cancer. There's actually some data that exosomes are helpful to suppress cancer, but because we don't have enough data, I'm not super comfortable with someone with an active cancer to use exosomes. So I'm working on a project to look at specific kinds of exosomes down the road. But right now, I would say I wouldn't want to treat someone who has not been in remission for a good amount of time. But if someone comes in and they're interested in this, I would make sure they're, hormonally optimized and everything else is, their diet, sleep, supplements and exercise that they can do. Of course, if your knee's blown out, you're not able to do a lot with that leg, but you can do an arm bike, you can do push-ups. There are a lot of things you can do, and the more motivated you are, the better. And the more motivated you are to try and avoid surgery, why not try a regenerative injection? Give it a few months. We sometimes see early benefit in pain in a degenerating knee after injection just from the anti-inflammatory benefit. And then the regenerative benefit we've seen starting to kick in at 3 to 4 months, where people are functional. There are a couple of, if you check out the social media there, I think we have a couple of videos that show people, like painful walking, but 4 months later they're taking dance lessons, and it just warms the heart.
Yeah, it's pretty exciting. I know that I've witnessed some just remarkable. And what's surprising is that what you said is there's this like delayed response. Oftentimes there's the initial side of it, and you're like, oh, I don't know if this is working. I'm unsure, doc, this sort of thing. And then like, oh, and the weird thing about pain or lack of movement is as it gets better, you almost forget how it was unless you're monitoring it, right? It's really bizarre.
We see that a lot, actually. It's kind of funny.
Yeah, that's where documenting evidence and, things like, perception of pain, range of motion, mobility, all these stuff that, like your actual functional capacity and these kind of like qualitative aspects of how a patient would describe it versus the quantitative response. And oftentimes they don't necessarily match. Like, oh yeah, that for some reason my knee doesn't seem to bother me anymore. Well, yeah, we just did this treatment 4 months ago. Yeah, doc, but I got this thing in my neck. It's like, well, let's go to the knee. What happened over there? Well, yeah, that's not bothering me, but I got this thing going on.
It's funny you say that, because one of my favorite professors used to say there's no lobe in the brain that has a memory for pain. And you can remember having pain or how it laid you up or something, but you can't remember, you can't duplicate it. You can't, we don't have an evolved part of our cortex of the brain that allows that.
Yeah, it's fascinating about the whole pain concept. I always classified pain as an athlete as a heightened sense of awareness. And there were two types of pain that you experience as an athlete, that which produces an improvement within your capacity to exercise or relative to your sport. In other words, you're pushing your limit and your body is, breaking down on one level or incapacitated. And then there's a regenerative process. And then there's the pain that is, oh, let's stop right now because that is, and they're different. They're different terminologies. And I think most athletes have cultivated the difference between those types of pain just out of exposure and experience. But the pain of a serious medical condition is often pervasive. And a lot of people will often seek pain relief. And unfortunately, we have an opioid epidemic. Like, for example, when I went for a surgery, a small surgery a year ago, cosmetic piece, and I was shocked that they prescribed opiates for pain, like at the pharmacy. I'm like, are you kidding me? And I said, I don't want any painkillers. And because I just saw, well, I'm going to experience a little bit of discomfort. And do you think, there's certainly a use for pain medication, but some people say, and I'd like to get this clarified from someone who would know, do you feel that opiates or other pain medications can inhibit the healing process?
I'm not aware of that specifically. Listen, I've prescribed, short course of opiates for people who've had surgery, right? Surgery can be painful, and you got to get through that first week or 10 days after surgery. So, most of my career has involved some limited use of that. I'm not someone who treats chronic pain with medications. That would require a different type of doctor. But I'm not aware of any narcotics that can worsen the injury. But tapping back into biochemistry through all this regenerative medicine, opioids bind a receptor. There are different versions of the receptor, right? And I'd have to go and look and research, do those receptors have a role in cell function vis-a-vis optimal anti-inflammatory, regenerative, healing? I don't know the answer to that. It's a great question. It's a great question. I don't know.
Yeah, because for myself, I've intuited, and that could be a false intuition. And that's why I want to kind of figure that out. Because I always wanted to avoid any pain medications under that guise of it's a heightened sense of awareness. And if I have awareness going somewhere, to me, my body is going to direct resources in order to get me back to what is considered normal functioning. And so I don't know if that's true or not biochemically. I've just felt it that way. And I'm kind of in between my mom. My mom's a very slow recoverer. I'm a medium recoverer. My dad is he's like Wolverine. He's had all these, life-threatening situations and surgeries and stuff. And then he heals and doesn't have you can't even see the scars on him weeks after major surgeries, heart surgery, neck surgery. It's just it's amazing where people are on that scale. My dad and I both try to avoid the pain medications for that same reason. And we both feel that, hey, regeneration, and I don't have the Wolverine gene like my dad does. Wish I did. But I certainly feel that it accelerates. So let's switch gears a little bit, because you've also, you have this Recelebrate. It's anti-aging in regenerative medicine. So we talked essentially about regenerative components. You've got an injury, you've got something that requires a surgery, you've got whatever condition you're using these. But how are you using these regenerative technologies from I don't even know if we can use anti-aging under the current regulatory, pro-aging or pro, I don't know what you call it. I don't know what the terminology. I'm always mindful of that.
I think we can speak freely, despite a lot of censorship. This is for general education purposes, so we're not giving medical advice to any one individual. So I think we could talk to anti-aging medicine. And yeah, I mean, listen, if we give you a dose of what the youth has, you will feel it. This is not new science. You take the blood of an old mouse, you give it to the young mouse, and the blood of the young mouse, you give it to the old mouse. The mouse will exhibit some of the attributes and behaviors of the other mouse, right? It goes with the blood. Why? Because the cells in the blood and the proteins, the growth factors, and the exosomes from the stem cells are being transmitted through that blood. So, and one reason, you and your dad, and especially your dad, heal better is because your exosomes are probably more robust in BPC 157 that's made naturally and things like that. So, we do IV exosomes, and I do it myself multiple times a year. I do also scalp exosomes so I can keep a lot of this.
Yep.
And we have the biohacking and anti-aging crowd that loves to do this stuff, and we love to meet those people and optimize them. And we do biological age tests and inflammatory markers. We look at their HRV, their heart rate variability, which is a great sensitive health metric from day to day, and we've seen some really cool results there. We've also used these IVs in elderly to help stimulate cognition, aches and pains from diffuse, arthritis. We've used it to assist with people with autoimmune problems, because I think autoimmune is really a hyper-inflamed state.
Yes. Yeah.
So we use regenerative because it is anti-inflammatory. It's the most powerful anti-inflammatory thing you can do. You might say, why don't I just take a whole bottle of ibuprofen then? Because first of all, that'll ruin your kidneys and your stomach. But secondly, ibuprofen only turns off one pathway of inflammation, and our cells have all kinds of redundancies and overcompensating yin-yang cycles. So if you turn off one, the other ones turn on more. So you can't use pharmaceutical anti-inflammatories like that. You could do kind of steroids like prednisone and suppress your inflammation system, which guess what? A lot of doctors do for autoimmune syndromes. And guess what happens? Those people age faster. They degenerate faster.
Mm-hmm.
So, those are the kind of things we address. We also do inhalational exosomes for people with trying to help their lungs from long COVID or bronchitis, or if they become oxygen independent. We've been able to get some people off oxygen. We have a nurse practitioner in our office who does a facial microneedling procedure to help. You think about the vampire facial, right? The PRP in the face. The exosomes are many times more bioactive and effective than PRP.
Yeah, I have a lot of people are using a combination of the two, the stem cells, exosomes, and the PRP all in one, and injecting sites on the face for regeneration. The results are incredible. Also for hair growth as well. I've seen that used, and I'm extremely impressed. From a general anti-aging perspective, I'm curious because I've thought about this a lot, and I don't know the cadence, and it may be age related. So right now I go twice a year where I take a course of stem cells and peptides and exosomes, and I will use some particular peptides, some of them for cognitive stuff, some might be for other avenues that I want to play around with. And I've been told, and I don't know if this is true, it's been suggested to me that about every 6 months is a good cadence for a guy my age in his 50s. And I do seem to feel like almost like an invert. I call it like aging is kind of like a glacier coming down the mountain. You don't really notice that it's moving until all of a sudden it's like, wow, how did that go? Because it's like, and physiologically. And when I've experimented with those treatments, it feels like the glacier went up the hill a little while. It's like my movement, the way my energy, my drive around, particularly around athletic performance, because that's the gauge.
Yeah.
The gauge that I can measure. I can measure how hard I want to run or how often I want to hit the gym. The other thing is there's without a question the cognitive clarity that I've had since engaging in those processes is significant. I do combine that with neurofeedback as well. I use them as complementary medicines. What is your take on the whole idea about frequency? How much is enough? How much is too much? And what's the Goldilocks zone from your perspective? Because you got a lot more experience than I do.
Well, I think that everyone's an individual, and you have to, we call this precision medicine, right? What's best for you? And, one measure of age is this model of accumulated inflammation on a chronic basis. And the faster you accumulate that, and the more you accumulate, the older you look and feel and act. So regenerative medicine helps pull that back like the glacier, and how much one person needs depends on how much they've accumulated. So we usually start with one treatment and we track the patient. How do you feel? And we get a lot of the same benefits you spoke to: energy, mobility, recovery from workouts, cognition, drive, motivation, libido, all those things. And sometimes more. We have all kinds of new things we learn about all the time. But if someone says, hey, that's petered off after 3 months, okay, looks like 4 times a year is about right for you.
Right.
So we can also look at HRV and biomarkers in addition, although I don't like to just treat lab tests, just like I don't just treat MRIs, right? I treat people. And but if we can figure out some measurements that go with that, oh yeah, when my C-reactive protein is 4, I'm in trouble. I want to keep that low. When my glycan age or my Dunedin pace or DNA markers, whatever age tests we're using, or other inflammatory markers, we can use those to find what Goldilocks is for an individual. Then we know the answer. Just like testosterone optimization, one guy needs it at 900, the other guy's great at 650, and they're the same age, right? It's just depending on the individual.
Yeah, I think a lot of people, there's been so much waiting just on the chemistry. And there's so many different interactions when you get into this that unless someone can marry data and observational components, which I think is a key aspect of individualized medicine, as well as the feedback from the patients. In other words, the more vectors you have to look at something, the more likely you're able to come to the right conclusions.
The other word for that is large language model, like ChatGPT.
Yes.
That's exactly what you're saying.
Yeah. I used to say wide scope accounting versus low resolution observations or conclusions. And 100 years from now, we'll probably think that we were in the Stone Age. I sure hope so, with the growth
we
of
are.
everything.
Yeah.
But we are where we are, and I think it's maybe the most exciting time in the realm of healthy aging. Whether we can extend our lives longer, that's unknown at this point. But I'm 100% confident we can increase the quality of one's life. And I really loved in Peter Attia's book, his most recent one, where he talked about the last 10 to 20 years of life and what its potential contribution in a multi-generational facet can provide. And I love that so much, because we've taken a lot of our older people in the last 40 or 50 years, and rather being celebrated elders and advisors to the fluctuations of life, they've been often stuffed in a home, drugged up on medications, and really removed from their really contributive part. And of course, social interaction is a big aspect of longevity,
right?
Which they're now studying with the blue zones and stuff, and having a purpose. And I was fortunate enough to have 4 centenarians on my block where I grew up. One, she's still alive today. She's 106. And she doesn't do any regenerative medicine. However, her social connectivity, and there's something to look forward to, and she's making mittens, and she's doing these things, and she has just such a positive attitude despite her many limitations. And I'm looking at this woman and I'm like, she's got a better attitude than almost anybody you'll meet at whatever age. And I really feel that that's powerful. Where can people find out? Oh, go ahead, please.
No, I got to insert there. She is doing regenerative medicine. She is doing it through all the lifestyle factors. She has learned the positive cellular benefits of the social interaction and keeping active and being optimistic and all those things. It is. There are great studies showing, for example, yoga will improve your stem cell activity. She's found it the old-fashioned way, but she is doing regenerative medicine.
Yeah. So where can people find out more? And what's really interesting now, I think also, it sounds like that you also do video consultation, that sort of stuff as well. So it was one of the great things I think that happened out of COVID is they implemented, telemedicine, which allowed access, regardless of where you might find yourself in the country,
right?
Because most rural people don't have access to, really high level regenerative technology, but they might want to have it. And so now that's available through telemedicine. I think it was one of the great benefits that goes unnoticed from all the negative outcome that's happened to that and all the politicization of everything. Where can people reach you? How they find out more? What's the process? All that stuff. I want to hear everything that you can help more of our listeners.
I agree with your silver lining of COVID is we get telemedicine, but there is a downside. The downside is we lose the physical exam, and so many doctors fail to apply that important, basic, fundamental aspect of medicine is a good history, ask lots of questions. You listen because we're pattern recognizers, and examination because there's so many signs and findings that I pull out on an examination that I can't do through telemedicine.
Yes.
And it is only through correlating those data points, that evidence with whatever tests we have, images or blood tests, where we correlate it all and come up with the most probable issues going on. Otherwise, you're blind. So even patients that, I treat a lot of patients from far away. We get MRIs. I look at the MRIs. We share the screen. Here's what I see. They still have to come see me the day before a procedure so I can examine them, just in case there's something that doesn't fit. I can always cancel, right?
Yeah, and I think that's fair too, because the thing what I like is, okay, you've got that initial access. You can do some comparison analysis. You say, okay, you know what? Hey, I want to go with doc so-and-so. And then you come into the office where before you didn't even know that person existed and had no capacity to access them if you were in a suboptimal place for expertise, which most people are.
Right. Well, I'm currently practicing out of Las Vegas, Nevada, actually Henderson, Nevada, which is a suburb of Las Vegas for those who don't
Love
know.
Henderson.
And I am seeing most of my patients initially remotely like this by Zoom or what have you. And we break it all down. We take the time, we go through your life, your lifestyle, your problems. I love new challenges. I love things that haven't been figured out. I love to do second opinions. It doesn't have to just be spine. If you've got something different and you just want a new angle on it and I don't know about it, I'll look it up. And I love that part. If it has an inflammatory component to it, regenerative medicine may be able to help it improve. I'm saying that cautiously because, we have to be very cautious about how we present these things. I'm not going to make any claims I can cure or treat anything, but I don't think I ever really have in any facet of medicine. Oh, they can find us online. Recelebrate is our brand, recelebrate.com. We're on Recelebrate on Instagram, TikTok, LinkedIn, Facebook, whatever. If you just type in Recelebrate, you'll find us one way or another.
We'll put all those links in the show notes. But most importantly, I think this is super informative. Thank you for the clarity, and it's particularly about all these nuances that I wonder about, and I know our listeners wonder about. You've done a great job of clearly stating those components, and I think our listeners have got a lot out of that. Thank you so much for that.
Appreciate it.
And of course, for our listeners on the Awesome Health Podcast, if you want to check out Jeff's work, please go to the sites, follow along, and share that with someone that you love that may be just falling into a surgery, and there's other options that could be really great. As well as if you want to live a long time, maybe you got little grandkids and you're worried about seeing them grow up and graduate and all of the fun things that you get to enjoy as a grandparent or even as a late blooming parent, then these are some things that can extend your capabilities and capacity for life and to influence those next generations. And I think that's one of the most exciting aspects of this. And one of the reasons I'm a proponent of it, I want to thank you for taking time out of your clinic as well for giving us such great information. I really appreciate it. And for all our listeners, thanks so much for joining us. I'm Wade T. Lightheart from Bioptimizers. This is the Awesome Health Show. We'll see you on the next episode.
At Bioptimizers, our mission is to fix digestion. And a cornerstone of digestion is gut flora. P3OM is our patented probiotic formula. In fact, we call it the Navy SEALs of probiotics. You see, strong proteolytic or protein digesting activity is paramount to having a healthy gut flora. And of course, P3OM provides that. The good news is, unlike weaker probiotics, P3OM survives the digestion process. What it does is it basically multiplies the good guys while protecting you against pathogens, or what some people call the bad guys. P3OM really helps to rebuild your digestion. And what that allows you to do is to maximize nutrient uptake, energy, and metabolism. To find out more of how P3OM can help you, go to www.bioptimizers.com.
Thank you for listening to the Bioptimizers Awesome Health Podcast. You can find more information at bioptimizers.com.